Hello guys, welcome to our channel. So today we are going to talk about hypertension or high blood pressure and also the pharmacology of antihypertensive drugs. So here first we will be talking about what is hypertension. As you all of know that hypertension is also known as high blood pressure. So the blood pressure anything that is above 140 or 90 millimeter of mercury, that is called as hypertension or high blood pressure. So the question arises here that the patient comes to you and he has a blood pressure of 140 upon 90 or greater than 140 upon 90 millimeter of mercury. So can you say that this patient has hypertension? So definitely the answer is no. You cannot say that this patient has hypertension because there is a criteria for diagnosing the patient with hypertension. So if this patient comes to you 2 to 3 times or 2 to 4 times on over a period of few weeks, like say let's say 3 to 4 weeks, and you measure his blood pressure and you have taken this blood pressure and this his blood pressure comes out to be consistently elevated beyond this reading, beyond or greater than 140 upon 90 millimeter of mercury. So you can say that this patient has an established diagnosis of hypertension. Okay, so there's a criteria for diagnosing a patient with hypertension. Next thing is that it's a very global problem faced by the modern world. Estimated of 1.2 billion people have hypertension, but only 46% people are actually aware of their hypertension status. That means only 46% people or patients know that they have hypertension or high blood pressure. So among these 1.2 billion people, only 42% people are actually being treated for their condition, treated for high blood pressure. And also only 21% people have their blood pressure under control. Okay. So this pharmacology of antihypertensive drugs topic is going to be very important. And here you can learn what is the management of hypertension and what are the various drugs and drug classes used in treatment of hypertension. So the next thing here we will discuss about is stages of hypertension. So according to American Heart Association, so there are four stages of hypertension. First is normal blood pressure. As you know that normal blood pressure is 120 upon 80 millimeter of mercury. So second thing they have classified this as elevated blood pressure. This is 120 to 129 systolic and 80 to sorry, and this is less than 80 or less than or equal to 80 millimeter of mercury. So this is called as elevated blood pressure. Stage 1 hypertension is when the blood pressure is 130 to 139 systolic and 80 to 89 diastolic. So this is called as stage 1 hypertension. In stage 2 hypertension, the blood pressure is greater than 140 systolic and greater than 90 diastolic. So this is called as stage 2 hypertension. Also there is a thing called as hypertensive crisis. Okay, hypertensive crisis. So hypertensive crisis is when blood pressure is systolic blood pressure is greater than 180 and diastolic blood pressure is greater than 120 millimeter of mercury. So this condition is called as hypertensive crisis and it needs the immediate attention of the healthcare professional. So these are the stages of hypertension, that is normal blood pressure, elevated 120 to 129 systolic and less than 80 diastolic. And stage 1 hypertension is when the blood pressure is 130 to 139 and diastolic is 80 to 89. Likewise, the stage 2 hypertension is greater than 140 upon 90 millimeter of mercury. So this is called as stage 2 hypertension. And in hypertensive crisis, this is defined as the blood pressure of greater than 180 and systolic and greater than 120 diastolic blood pressure. So this is the definition and the stages of hypertension. Next, we will be talking about the classification of antihypertensive drugs. So next we will be talking about the classification of hypertension or classification of antihypertensive drugs. So first of all, here the first class is ACE inhibitors, angiotensin converting enzyme inhibitors, and the drugs in this class are captopril, enalapril, lisinopril, fosinopril, ramipril, perindopril, zofinopril, and imidacloprid. So here you have to know that these three drugs, that is perindopril, zofinopril, and imidacloprid, these are relatively newer antihypertensive drugs, or you can say newer ACE inhibitors. which are recently included in the market. So also the ACE inhibitors, these drugs end with pril. So any drug that ends with pril is an ACE inhibitor, angiotensin converting enzyme inhibitor. Next is angiotensin receptor blockers. So the drugs in this category are candesartan, valsartan, losartan, telmisartan, irbesartan, and olmesartan. So as you know, these drugs end with sartan. Okay, so any drug ending with sartan is an angiotensin receptor blocker. Next is going to be beta blocker. So here these drugs end with LOL, lol. Okay, as in propanolol, metoprolol, bisoprolol, corvidolol, and etinolol. So also these beta blockers are actually subdivided into two categories, that is non-selective beta blockers and selective beta blockers. So this drug, that is propanolol and etinolol, these are non-selective beta blockers. That means they block both beta 1 and beta 2 receptors. This metoprolol, bisoprolol, and corvidolol, these are selective beta 1 blockers. So they block only beta 1 receptor. So these are the important features of beta blockers. Next, we are going to talk about calcium channel blockers. So these are actually subdivided into two categories of drugs, that is dihydropyridines and non-dihydropyridines. As you can see here, that amlodipine, felodipine, nicodipine, nifedipine like drugs. So these drugs are called as dihydropyridines. So that means they are actually derived from a chemical class of drugs called as dihydropyridines. And so also the non-dihydropyridines like verapamil and diltiazem. These two drugs are also calcium channel blockers, but they are not dihydropyridines. They are non-dihydropyridines. Okay. So next thing is here diuretics. In this, they are subdivided into loop diuretics, thiazide diuretics, potassium sparing diuretics. As you can see here, that loop diuretics include furosemide, torsemide, and bumetanide. And thiazide diuretics, they include chlorthalidone, hydrochlorothiazide, and indapamide. And also the potassium-sparing diuretics, these drugs include spironolactone, eplerenone, and amiloride. We will be talking about the diuretics group of drugs in our later videos on the channel. So here we will only be talking about the antihypertensive effect of diuretics. Okay. So the next thing is going to be directed renin inhibitor. So this example in this include L-skyrine. So this drug L-skyrine is a directed renin inhibitor. And the next thing here is going to be other drugs. So what are the other drugs which are used in treatment of hypertension? This is actually, they don't belong to any of the above classes discussed above. So these are clonidine, methyl dopa, phenol dopam, nitroprusside, hydralazine, and minoxidil. Here you have to remember one thing, that this clonidine and methyl dopa, these drugs are also called as central sympatholytics. Okay, central sympatholytic drugs. That means these two drugs, clonidine and methyl dopa, they act via central nervous system. Okay, so these are the drugs which act on central nervous system and are antihypertensive drugs. So phenol-dopam, nitroprusside, and next is hydralazine and minoxidil. So here you have to remember about this minoxidil, that it was earlier used as hypertensive agent, but nowadays it is not used as an antihypertensive drug, because the one of the side effects of this drug is that it causes the hair growth. Okay, it causes hair growth. So this drug was later approved by the FDA for the treatment of hair loss. Okay, this is nowadays used for the treatment of hair loss. This comes as a topical solution, minoxidil. So it is nowadays used for the treatment of hair loss in both males and females. So this is regarding the classification of antihypertensive drugs. Next, we'll be talking about each individual class in detail. So the next category of drugs here we will be talking about are ACE inhibitors or angiotensin converting enzyme inhibitors. So first of all, we will be learning about the mechanism of action of these drugs. As you know that there is a protein called as, this is known as angiotensinogen. Okay, angiotensinogen. So this angiotensinogen is present in the blood, and this is converted into angiotensin 1. Okay, and this angiotensin 1 is later converted into angiotensin 2. So here this is converted into angiotensin 1 with the help of renin. Okay, so this renin comes from kidneys. Okay, this renin comes from kidneys. And this angiotensin 1 is further converted into angiotensin converting enzyme with the help of angiotensin 2 with the help of angiotensin converting enzyme, and this comes from lungs. Okay, so here angiotensinogen is converted into angiotensin 1 and angiotensin 1 is converted into angiotensin 2 with the help of angiotensin converting enzyme which comes from lungs. So the main thing that is important in blood pressure is your angiotensin 2. So what angiotensin 2 does, it actually causes the release of aldosterone from the adrenal medulla. Okay, aldosterone release. Second, it is a vasoconstrictor, so it causes vasoconstriction. Okay, and the third thing it causes is that it increases the sympathetic activity. It increases the sympathetic activity. So all these three mechanisms, that is aldosterone release, vasoconstriction, and increase in sympathetic activity, lead to increase in blood pressure. So how they increase the blood pressure is that aldosterone, as you know, that this aldosterone, it promotes the reabsorption of sodium and water. It promotes the reabsorption of sodium and water in the nephron. Okay, so when sodium and water are reabsorbed into the body, that means what it does is that blood volume increases. When blood volume increases, preload increases. Okay, when blood volume increases, preload increases, and when preload increases, cardiac output increases, and when cardiac output increases, this leads to increase in blood pressure. Also, the directive vasoconstriction caused by this angiotensin 2 also elevates the blood pressure. And third thing is that increase in sympathetic activity, that is there is increase in sympathetic outflow. That means an epinephrine and norepinephrine are released in more concentrations, and that is why the blood pressure increases. So all these three factors lead to overall increase in blood pressure. But here we are talking about the angiotensin converting enzyme inhibitors. That means our goal is to lower the blood pressure. So what angiotensin converting enzyme inhibitors does, they block this enzyme. Which enzyme? Angiotensin converting enzyme. And as a result of this, angiotensin 1 is not converted into angiotensin 2. So there is no aldosterone release, there is no vasoconstriction, and there is no sympathetic activity. And as a result, there is no increase in blood pressure. So this is the mechanism of action by which the angiotensin converting enzyme inhibitors work. So next we will be talking about what are the properties of ACE inhibitors. So what are the properties of ACE inhibitors? So you can remember the properties of ACE inhibitors by remembering CAPTOPRIL, by remembering this mnemonic captopril. So C stands for cough. Okay, so this is the side effect of ACE inhibitors, that is dry cough. It is one of the common side effects that is associated with angiotensin converting enzyme inhibitors. Okay, so another thing is A stands for angioedema. Angioedema. So this leads to the swelling of skin in different parts of the different areas of the body. That is angioedema. This is another side effect of angiotensin converting enzyme inhibitors. So the next thing is that P stands for prodrugs. Okay, so this these ACE inhibitors, these are prodrugs, except lisinopril and captopril. Except lisinopril and captopril, all other ACE inhibitors are prodrugs. Here O stands for orthostatic hypotension. Okay, orthostatic hypotension. Hypotension, as you know, is low blood pressure. So this phenomena occurs, orthostatic hypertension, when you stand up from the sitting position. So you experience this orthostatic hypotension, and that is seen particularly with AC inhibitors. Another thing is pregnancy. Okay, so these AC inhibitors are contraindicated in pregnancy. That means these are not used in patients who are pregnant and who are having high blood pressure. So these are not drug of choice in that case, and these are actually contraindicated in pregnancy. Next is R stands for renal artery stenosis. Okay, renal artery stenosis. So this renal artery stenosis also, these patients, these drugs are contraindicated in patients who are having renal artery stenosis. Okay, next is increase. I stands for increase potassium. Okay, increase in potassium. So these drugs lead to hyperkalemia. L stands for lower complications of diabetic nephropathy. Okay, lower complications of diabetic nephropathy. Okay, so these drugs, they lower the complications of diabetic nephropathy. That means ACE inhibitors, if they are giving in those patients who are having diabetes and whose nephrons are damaged, so we can give these ACE inhibitors in these patients because they lower the complications of diabetic nephropathy. So these are the different properties of ACE inhibitors that you can remember by the mnemonic captopril. Okay, as you can see here, C for cough, A for angioedema, P for prodrugs, and T for, sorry, I forgot to mention here, T is for taste alteration. Okay, T is for taste alteration. So this is another side effect that is because of these drugs, that is taste alteration. O is for orthostatic hypotension. P is for pregnancy, that is these drugs are contraindicated in pregnancy. I for renal artery stenosis, and L for increased potassium, and L for lower complications of diabetic nephropathy. So these are the different properties of ACE inhibitors. Next, we'll be talking about what are the different uses of ACE inhibitors. So the next thing we'll be talking about are the uses of ACE inhibitors. So these drugs are used in various conditions like hypertension. They are also used in congestive heart failure. These are actually the preferred drugs in congestive heart failure patients, and they are also used in acute myocardial infarction and also the diabetic nephropathy. So these are the different uses of angiotensin converting enzymes, that is hypertension, congestive heart failure, acute myocardial infarction, and diabetic nephropathy. So next we'll be talking about the drug-drug interactions of ACE inhibitors. So the next thing we'll be talking about is drug-drug interactions of angiotensin converting enzyme inhibitors. So the first drug-drug interaction is angiotensin converting enzyme inhibitors when they are giving along with potassium sparing diuretics. So there is an increased risk of hyperkalemia. Okay. So the next thing is angiotensin converting enzyme inhibitors into NSAIDs. So NSAIDs, they decrease the antihypertensive effect of ACE inhibitors. So these NSAIDs should not be co-administered with ACE inhibitors because they reduce the antihypertensive effect of angiotensin converting enzyme inhibitors. So the next thing here is angiotensin converting enzyme inhibitors into lithium. So when angiotensin converting enzyme inhibitors are given along with lithium, so this leads to lithium toxicity. So these are the various drug-drug interactions that are because of the angiotensin converting enzyme inhibitors that you should be you should keep in actually mind that while prescribing angiotensin converting enzyme to the patient, that you have to look for whether the patient is actually already on potassium sparing diuretic, whether he is already on NSAIDs, whether he is already on lithium. So in these patients, you have to adjust the dose, or you have to provide the alternative therapy for the treatment of hypertension. So the next thing that we will be talking about are the beta blockers. So as you know that these beta blockers, these are the drugs that end with lol, like propranolol, atenolol, carvedilol, metoprolol. So these drugs, what here we will be talking about what is their mechanism of action. So as you know that these beta receptors are located in various organs and tissues of the body. So here these beta 1 receptors are located in the heart. They are also present in kidney, that is beta 1, and also the beta receptors are present in brain as well, in the CNS as well. So what is their function? What is the function of the beta receptors in these organs is that uh, and we will be talking about the beta blockers. Like these beta blockers, they block these beta 1 receptors. Okay, they block this beta 1 in the kidney, they block this beta 1 in the heart, and they block the beta receptors in the CNS. So here what this leads to, that is when there is blockage of beta 1 receptors in the kidney, this leads to decreased production of renin. As you have already studied earlier in the ACE inhibitors mechanism of action, that renin converts the angiotensinogen into angiotensin 1, which is later converted into angiotensin 2 and which is responsible for the increase in blood pressure. So here when beta 1 is blocked, it leads to decreased production of renin. So this decreased production of renin leads to decreased angiotensin 2, and this decreased angiotensin 2 leads to decrease in blood pressure, and it helps us to lower the blood pressure. So this is the mechanism here when beta blockers they block the beta 1 receptors of the kidney. So next is heart. So when they block the when these beta receptors when these beta blockers block the beta 1 receptors in the heart, this leads to decrease in heart rate. So as a result, there is decrease in force of contraction. Okay, there is decrease in force of contraction. This leads to decrease in cardiac output. Okay, so this decrease in cardiac output, as we had discussed earlier, leads to decrease in blood pressure. So this is the mechanism by which the beta blockers block the beta 1 receptors of the heart, and this leads to decrease in blood pressure ultimately. Another thing is going here to be when these beta blockers they block the beta receptors of the CNS. This leads to what it causes is that it leads to decrease in sympathetic outflow. It leads to decrease in sympathetic outflow. Okay, so here the sympathetic outflow is decreased. As a result, when this is decreased, that means there is decreased release of epinephrine. There is decreased release of epinephrine and norepinephrine. Okay, so when these neurotransmitters are decreased, this leads to decrease in blood pressure. Overall decrease in blood pressure. So this is the mechanism of action of beta blockers. So the next thing here you have to remember about beta blockers is that they are also used in various other conditions, like the drug that is propranolol. Propranolol, this is also used in hyperthyroidism. Okay, this is also used in hyperthyroidism. So the patients who are having hyperthyroidism are actually given propranolol as a mm, as a prevention of hyperthyroidism. So also this propranolol is also given in patients for the prevention of migraine attacks. Okay, this is also given in patients who have migraine, and this decreases the migraine attacks in these patients. So here, as we have discussed earlier, that this propranolol, this is a non-selective beta blocker. Okay, this is non-selective beta blocker. That means it blocks beta 1 as well as beta 2 receptors. And here, as you can see that as we have earlier discussed that metoprolol, carvedilol, and bisoprolol. These are the beta 1 selective. Okay, so these drugs are the beta 1 selective beta blockers. So these are beta 1 selective beta blockers, and they are used in various cardiovascular related problems. Okay, so the next is going to be your labetalol. So this drug, the special thing about this drug is that this drug is actually used in hypertension in pregnancy. So this when if a lady is having, if a woman who is pregnant, who is having hypertension, so the drug of choice will always be, if you are giving beta blockers in this patient, so our drug of choice will be labetalol. So this labetalol is actually safe in pregnancy. Okay, so these are the important things about beta blockers. Next we will be talking about the calcium channel blockers. So next we will be talking about the calcium channel blockers, and first we will be seeing what is their mechanism of action. So as you know that these calcium channel blockers, there are actually two types of calcium channels present in the body, that is L type and T type calcium channels. Okay, so these calcium channel blockers, they block the L type calcium channels, and this blockage of L-type calcium channels, this leads to decrease in heart rate, decrease in force of contraction, and decrease in conduction velocity. So this is known as this decrease in heart rate is known as negative chronotropic effect, and decrease in force of contraction is called as negative inotropic effect, and likewise negative dromotropic effect is called as conduction, decreasing conduction velocity. So these negative chronotropic, inotropic, and dromotropic effect possessed by the calcium channel blockers, blockage of L-type calcium channels. So this leads to decrease in overall decrease in blood pressure. So also for for calcium channel blockers, you have to remember that nicardipine, this is a parenteral calcium channel blocker which is used in hypertensive emergency. So this is actually the longest acting parenteral calcium channel blocker approved for emergency, or you can say that this is the drug of choice. Okay, this is the drug of choice for hypertensive emergencies. Okay, so next thing is this clavidipine. This is very ultra short acting. Okay, ultra short acting. This is not USA. This is ultra short acting clavidipine calcium channel blocker, which is also approved for treatment of hypertensive emergency. Okay, hypertensive emergency. Also, drugs like verapamil and diltiazem. Okay, drugs like verapamil and diltiazem. So these drugs are actually they are contraindicated in patients who are having heart block uh, or sick sinus syndrome. So in sick sinus syndrome or heart block, these patients, these calcium channel blockers are contraindicated because they can lead to severe decrease in these already worsened conditions like sick sinus syndrome and heart block. So these drugs are contraindicated in these patients. So these are the important features of calcium channel blockers. And here you have to remember one thing also, that this amlodipine, okay, amlodipine, this has very good pharmacokinetic profile, and this is mostly the preferred drug used in routine management of hypertension. Okay, so this is the used in routine management of hypertension. This drug amlodipine, because of it is excellent pharmacokinetic profile. So here next is diuretics, and in this we'll be talking about diuretics in a separate video, but here diuretics, as you know, these are the drugs which are used in only the as you know, there are three classes of drugs, that is furosemide like drugs, that is loop diuretics, okay, and next is loop diuretics, and there is thiazide diuretics, okay, thiazide diuretics, and the third is potassium sparing diuretics, okay, potassium sparing diuretics. So in the routine management of hypertension, only thiazide diuretics are used, that is hydrochlorothiazide or chlorothalidone. Okay, only these drugs are used for routine management of hypertension. So these loop diuretics, they are especially preferred in those patients who are having congestive heart failure, or who are having peripheral or lower extremities edema, or any kind of edema, that is swelling in the body. So these diuretics are then preferred, that is furosemide, torsemide, and bumetanide, that is two loop diuretics. They are only used if the patient has congestive heart failure and if it has edema or swelling in the body, then these are the preferred drugs. For the routine management of hypertension, that is, these thiazide diuretics are used because they are given as once daily dosing. Okay, so these are the important features of thiazide diuretics, which are important as far as hypertension is concerned. So the next thing here we'll be talking about is central sympatholytics, and in this the drugs are clonidine and methyl-dopa. So first of all, we will be looking at the mechanism of action of central sympatholytic agents. So in the brain there are alpha 2A receptors. So what these alpha 2A receptors does, it decreases the sympathetic outflow. So this clonidine, it actually stimulates the alpha 2A receptors. Here you have to remember that it does not block it, it stimulates the alpha 2A receptor, and there is decrease in sympathetic outflow. So this decrease in sympathetic outflow has effects on the heart and also the effects on the blood vessels. So in the heart, there is decrease in heart rate and cardiac output, which leads to decrease in blood pressure. And in the blood vessels, there is decrease in peripheral vascular resistance, and it also leads to blood pressure decrease. So here, what is peripheral vascular resistance is actually the resistance that is offered by the blood vessels to the flow of the blood. Okay, so when there is increase in peripheral vascular resistance, there is increase in blood pressure. So increase PVR means increase blood pressure. So when peripheral vascular resistance is decreased, that means that is decrease in blood pressure. So what decrease the peripheral vascular resistance? It is the stimulation of alpha 2A receptors, which in turn decrease the sympathetic outflow. That is the that means decrease release of adrenaline or epinephrine and norepinephrine. Okay, so there is decreased release of adrenaline and norepinephrine. So this leads to decrease in heart rate, which leads to decrease in blood pressure, and also there is decrease in peripheral vascular resistance, which leads to decrease in blood pressure. So there, this clonidine is also used in hypertension, as obvious, and it is also used to treat withdrawal symptoms in opioid and alcohol addicts. So in opioid and alcohol addicts, they when these patients are having the withdrawal symptoms, they are using this clonidine is used to treat these withdrawal symptoms in these patients. It is also used as a pre-anesthetic agent. As you know that this clonidine, this gives the stable blood pressure a reduction in patients who are actually going to have surgery. So before the surgery, the blood pressure and also in the patients for which we need the controlled in the maxillary, oromaxillary facial, in the dental surgery where there is a need of hypotension. So this clonidine plays an important role there. It is used as a pre-anesthetic agent because it leads to stable blood pressure in these patients, and also it is also used as a pre-anesthetic agent because it has also the mild sedative and analgesic properties. So because of all these features, this clonidine is used as a pre-anesthetic agents. Also, this is also used in prophylaxis of migraine. So for the prevention of migraine attacks, this clonidine is also used there. So this was regarding the central sympatholytic drugs, that is clonidine and methyl dopa. So also here you can remember one thing, that these drugs, that is clonidine and methyl dopa, these are safe in pregnancy. That means you can give these drugs in patients who are pregnant and who are having hypertension. So this was regarding the central sympatholytics, their uses and their mechanism of action. So next I will be talking about the alpha blockers. So the drug in this category is prazosin, terazosin, doxazosin. So here we'll be talking about the prazosin, that is a typical alpha blocker. So this drug blocks the alpha 1 receptors, and this is an alpha 1 antagonist. So this blockage of alpha 1 receptors leads to dilation of blood vessels. So as a result, there is decrease in blood pressure. As a result of dilated blood vessels, there is decrease in blood pressure. So the next thing regarding this prazosin is that it causes the first dose effect. So it causes the first dose effect. Okay, it causes the first dose effect. So this is given initially as a dose of 0.5 mg initially, once daily dosing. Okay, so this first dose effect is particularly seen in patients who are elderly patients, and what happens is actually there is decrease blood pressure, there is severe hypotension, and the patient may faint because of the first dose effect of prazosin. So this is initially given as a low dose of 0.5 mg, and then this dose is increased to twice daily, that is twice daily dosing. So gradually this dose is increased to twice daily dosing to decrease the chances of first dose effect due to prazosin. And next thing is about the side effects of this alpha blockers. So the primary side effect is insomnia, and another is premature ejaculation, postural hypotension, and priapism. So that means painful ejaculation. So next are the what are the uses of alpha blockers. So the use is mostly it is used in hypertension. It is also used in patients with benign prostatic hyperplasia. So these are the main two uses of alpha blockers. So this was regarding the mechanism of action, side effects, and the uses of alpha blockers. So next we'll be talking about sodium nitroprusside. As you know that this sodium nitroprusside, it releases the nitric oxide. So this nitric oxide, it is a vasodilator as well as arteriodilator. So with the help of vasodilation, it leads to decrease in preload and decrease in cardiac output, which ultimately leads to reduce and decrease in blood pressure. So, by arterial dilation, it leads to decrease in peripheral vascular resistance, which leads to decrease in afterload and which leads to decrease in blood pressure. So, this is the mechanism of action of sodium nitroprusside. One thing you have to remember here that it is both arterial dilator as well as venodilator. This is the commonly asked question in the entrance exams. So this now sodium nitroprusside, it is an arterial dilator. That means it dilates arteries as well as veins. Next thing is the dose given is usually 0.25 to 1.5 mcg per kg per minute. It is given as an IV infusion in 5% dextrose solution. So this is the dose that is used in that's given for sodium nitroprusside. So this drug is also used in hypertensive emergencies. So when there is no obvious decrease in blood pressure seen in patients with hypertensive emergency, we give this sodium nitroprusside to reduce the blood pressure. So this was regarding the antihypertensive drugs. Hope you have liked this lecture. If you want to learn more about pharmacology, and we will be uploading more and more videos in this channel shortly. So if you like this video, please subscribe to our channel. We will be uploading more and more videos in future. Thank you for watching this video. Thank you once again.